for babies born too soon symposium. Before I get into the meat of the matter, just some quick housekeeping issues. So everyone will be muted throughout the symposium, throughout the discussion. There will be a question and answer section at the end. And additionally, place all your questions in the chat, and someone will pick those up and have them posted. All right. So once again, I am Jerry Main, and let me also tell you my panelists for the evening. I'm not alone, and it's baby talk for this evening, and it's the perfect weather as well. Couldn't be better. I don't know where you are, where each of you are, but where I am, it's quite cool and lovely. Right? Baby weather. I'll leave all the making for this evening, but it's what got us here, right? So let me first first introduce Dr. Jennifer Young. She is the assistant professor in the Department of Pediatrics and a staff neonatologist at the Mount Sinai Hospital. Also with me this evening is Dr. Tiffany Hunter. And I'll tell you what, I'll also go into the full details and give you the full credentials of my panelists when it's their time to speak also. Dr. Helen Trotman, a professor in the Department of Child and Adolescent Health at the University of the West Indies, the Faculty of Medical Sciences, MONA. Also with me this evening, Dr. Sydney Roden. Of course, she would have completed her DM pediatric program at the University Hospital of the West Indies some 10 years ago. And I'll, of course, like I said before, I'll bring you up to speed with her full bio also. Nurse Claudia Nelson Rodney is also with us this evening, in addition to Ms. Simone Forbes, who will be joining us, as well as Mrs. Shireen Williams Hemmings, and additionally, Professor Audrey Pottinger will also be with us. And I couldn't go further without saying good evening as well to Dr. Lewis. All right, so a brief background on the Caring for Miracles Foundation Prematurity Awareness Month. Now, the Caring for Miracles Foundation was launched in September of this year with a vision that all children, regardless of birthplace, are positioned to attain their full potential in all spheres. The foundation's mission is to ensure that every newborn has access to equitable, optimal healthcare, that is, by empowering neonatal units in low and middle income countries to deliver the best possible care to patients through capacity building, through education, equipping, nurturing resilience of the healthcare team. The foundation has decided to include a Prematurity Awareness Month as well as part of its schedule of activities in a bid to bring awareness to our local population of the problem, the challenges, the needs, and also the successes. Now, this is part of the intention to engage the community in the important and necessary work of the foundation, which seeks to level the inequity in healthcare provision for our most vulnerable. Now, each year, some 15 million babies worldwide, more than 1 in 10 births, are born prematurely, according to the 2020 Born Too Soon, the Global Action Report on Preterm Birth, done by the March of Dimes Foundation, the Partnership for Maternal, Newborn, and Child Health, Save the Children, and the World Health Organization. Now, according to SIM, apologies for that brief interruption. Now, according to the report from the 2020 Born Too Soon, more than 1 million of those babies die shortly after birth. Many others experience long-term physical, neurological, and/or educational disability, which present a significant emotional and financial burden on their families and society. As many as 75% of those preterm babies who die could survive without expensive care if a few proven and inexpensive treatments and preventative measures were available. That is worldwide. This according to more than 100 experts who contributed to the report, representing almost 40 UN agencies, universities, and organizations. Now, since 2003, the March of Dimes has led Prematurity Awareness Month activities in November as part of its Prematurity campaign. The goals of the campaign are to reduce rates of premature birth in the USA and raise awareness of this very important problem. So this panel discussion this evening is meant to shed some light on the problem and hopefully provide you with some tools to support families going through this difficult time. I must also say, I'm also the father of a premature baby, my son CJ Brown, who would have been at the NICU at the University Hospital of West Indies. And it was quite an experience for sure. So I am quite privileged and definitely honored to be a part of this evening's proceedings. And speaking of proceedings,
Jermaine, you're unmuted.
all right, am I being heard clearly?
Yes, we're hearing you now.
All right, so let me just backtrack a bit. So the first bit of discussion this evening will be the introduction to the concepts of the neonatology and the prematurity, and Dr. Jennifer Young will take us through this particular discussion. And let me,
can you hear
Dr.
me?
Young?
Yes, can you hear me?
Yes.
Okay.
Just before you begin, let me just right. Let me just give a brief introduction to Dr. Young. So Dr. Jennifer Young is an assistant professor in the Department of Pediatrics and a staff neonatologist at Mount Sinai Hospital. She keep disturbing me, man. The Dewey and the Orchids coach and all of them, man. See them ringing again. Jesus. All right. Once again, my apologies. Dr. Jennifer Young is an assistant professor in the Department of Pediatrics and a staff neonatologist at Mount Sinai Hospital. She is the director of the neonatal perinatal training program at the University of Toronto. Her areas of interest include medical education and neonatal transitional and community follow-up care. Her academic background really quickly, Dr. Young obtained her bachelor's degree from the University of Guelph. She then completed her medical training at the University of the West Indies, Mona campus, woo-woo, Jamaica. Then, of course, she underwent pediatric training there as well. She completed her neonatal perinatal fellowship training at the University of Toronto. She has successfully completed a diploma in clinical epidemiology at McMaster University. Dr. Young's research interests include Dr. Young's research interests are in the NICU, transitional care, and community peer-to-peer support. So Dr. Jennifer Young will take the platform now.
Thank you so much. I hope you can hear me.
Yes, I'm hearing you clearly.
Okay,
go ahead.
Thanks for your kind introduction. I will attempt to share my screen. Someone else is, okay, you're sharing, so I can't share. So
Okay, hold on.
someone needs
Hold
to
on.
stop sharing.
All right, let me.
Go ahead. Ah, perfect.
I will try to do this in presentation mode. I don't know if it will work.
Well, we're definitely hearing you. So
Okay,
you can continue speaking whilst you sort out your
all right.
video as well, your camera. So you
Okay.
can go right ahead.
So again, I wanted to thank the organizers of the Caring for Miracles Foundation, I know of which I'm a part, for the opportunity to share with you this evening. I titled this talk Born Too Soon, and I know that it's a caption phrase that's been used by many organizations. But here today, we're here to highlight the burden of prematurity on our local population as well as worldwide. The goals of today's talk would be, one, to introduce the concepts associated with prematurity, to build awareness about the effects of prematurity, and to support the optimal care of babies or infants born preterm. Also, in doing that, we want to be able to support families experiencing a preterm birth. Let's start with the definition. Prematurity is defined as delivery of a baby before 37 weeks of pregnancy. As we know, and I'm sure there'd be more discussion, a normal pregnancy lasts about 40 weeks. The incidence of prematurity, as mentioned earlier, ranges throughout the world, but generally speaking, 1 in 10 babies is born premature worldwide. I know it ranges in some countries from 7, 8 to about 15. But definitely this is the trend worldwide. And so each year on November 17th, we celebrate World Prematurity Day. There's 3 major categories of premature infants, which include the late preterm infants, those born between 34 to 36 weeks of gestation, of pregnancy. The very preterm, which are born between 28 to 32 weeks of gestation, and the extremely preterm, which are born less than 28 weeks of gestation. The causes of prematurity may include someone who has a multiple pregnancy, so twins, triplets, quadruplets, and so on. Sometimes there's evidence of infection. Sometimes there are chronic medical conditions that can be contributing factors such as diabetes and hypertension. And sometimes there may be genetic influences, because we know that prematurity or premature birth can run in families. However, often no cause can be identified. The course of a preterm infant can vary quite a bit in the newborn period. It starts with admission to the newborn unit. And this picture here just gives you a bit of an idea. This is one of my teams in our NICU. And this is where we care for various ages or babies of various ages and various degrees of illnesses. And that in itself can be a topic that we can discuss at length. It takes a special team of healthcare providers to be able to care for these patients, or tiniest of patients. They're the doctors or the physicians, the nurses. It also includes dietitians, a pharmacist, social worker, and also the parents who are part of the care team for their newborn. So this is a team, and there are multiple individuals here. We've got the nurses, the parents who are involved in the care, the physicians, the respiratory therapist, the pharmacist, dietitian, are all part of this care team. We care for babies at various ages and stages of prematurity, and definitely babies who are born and require significant intensive care are what we see on a day-to-day basis. Our goal is to help them to be strong, to get over each hurdle, and to be successful at the end of their journey. We do know, however, that the effects of prematurity can be many. To the baby, the effects of prematurity can affect the body and organ systems which have not yet completely matured. The smaller the size of the infant, right? We know that they're much smaller than a full-term infant, but we hope that after 37 weeks, they will at least be able to do and at least grow to a size of what we expect for a baby around 37 weeks. They may need help with breathing, eating, fighting infections, and just staying warm. And this means we need to provide for each of these basic needs that sometimes we who are capable may take for granted. And those born before 28 weeks are at greatest risk of all of these problems as mentioned. So the younger they are at birth, the higher the risk of having these concerns and needing treatment on a daily basis. There can also be effects on the family. We know that preterm infants can, or prematurity presents the family with an altered parent role. Sometimes there's a feeling of loss of control and definitely a feeling of fear, and that fear is of the unknown. We know that preterm families experience a higher incidence of depression, post-traumatic stress, and anxiety disorders, and also postpartum mood and anxiety disorders. This, we know, can affect or can alter parent-infant interactions. So again, the burden is great. It's 1 in 10 babies worldwide. Our goal at the end is definitely to have a baby transition from prematurity into a thriving adult, a thriving child, and hopefully a thriving adult. So I hope this just brings you a little bit of the awareness and just highlights some of the burdens that I'm sure will be discussed further. Thank you for your attention.
All right, thank you, Dr. Young, for your insight. I'm sure all of us would have learned from your presentation just now. And I'm sure there'll be questions as well. So, and those will come a bit later on. Now, further, as we go delve a bit further into this evening's discussion, We're going to be looking at the prematurity from the obstetric perspective, the local experience, screening for prematurity, risk factors, what to expect. And Dr. Tiffany Hunter-Greaves will be taking us through this particular aspect of the discussion. Dr. Hunter, can you share with us some of the local experience at the University Hospital of the West Indies with the preterm deliveries? And also, what are the risk factors? And how does one identify a woman at risk of preterm labor and delivery? Dr. Hunter-Greaves, before you begin, just let me just quickly introduce you wholesomely to everyone this evening. Of course, Dr. Hunter-Greaves completed the Bachelor of Medicine and Bachelor of Surgery, as well as the Doctor of Medicine in Obstetrics and Gynecology at the University of the West Indies. Now, due to her passion for obstetrics, she pursued a fellowship training in maternal fetal medicine at the University of Toronto and completed this in 2014. Dr. Hunter is currently a consultant and lecturer in the Department of Obstetrics and Gynecology at the University of the West Indies. Her research interests are medical disorders of pregnancy, such as cardiac disease in pregnancies. Dr. Hunter-Greaves will now take the platform.
Good night. Thank you very much, Jermaine, for that introduction. Thank you to the organizers for having me tonight. I'm really honored to be a part of this, these proceedings. So first, I'll just state what is the rate of prematurity in Jamaica. Currently, our rate is at about 8%. With respect to University Hospital in the West Indies, we're currently at 10%, and this is figures from our perinatal statistics in 2019. Now, what are the causes that we primarily see? Dr. Young outlined the general causes, and that is what we have been experiencing. But for us, I would say one of the main causes, maybe 50 to 60%, is iatrogenic preterm delivery, or that is indicated, medically indicated. A lot of our population has hypertension. So we find that women develop hypertensive disorders of pregnancy, whether it be pre-existing hypertension or within the pregnancy itself. And we commonly have to intervene in that. We have to deliver them early in order to prevent organ damage associated with high blood pressure. So that is a common thing. Also, so they can be delivered early due to maternal conditions such as hypertension, as well as fetal conditions, which is a growth restriction, which can come along with hypertension. Additionally, preterm premature rupture of membranes, that is when a pregnant woman breaks the headwater early in the pregnancy, quite often due to infection. So that is another major cause of preterm delivery, and then, well, that occurs, then preterm labor occurs, and then preterm delivery occurs. Also too, sometimes the labor can be spontaneous. Prior to 37 weeks, they spontaneously go into preterm labor for the causes that were previously outlined. Additionally, cervical insufficiency, meaning that the cervix, which is the, for the lay persons, that is the mouth of the womb or the uterus, it becomes weak or it becomes short, and it may dilate, that is open up prior to 37 weeks, or it becomes shorter. And there are ways that we, ways and means that we use to detect this early, so we can intervene. So those are the main causes I would say that we notice in our population. Now, how do we screen for this? So screening in the antenatal period, and even better yet, in the prenatal periods, for instance, preconception counseling, sometimes you can identify risk factors in a gynecological visit that would predispose a woman to a preterm birth. So if we can identify those early, then that would be ideal. So there are a myriad of risk factors that can be identified from the history, pre-pregnancy or early in the pregnancy. And This can be done at the first medical visit, and the screening really is ongoing throughout the pregnancy itself, because conditions can develop or situations can develop which will predispose a woman to going into labor later on. So certain risk factors that we try to elicit from the history include a history of preterm birth. That is one of the main risk factors for a subsequent preterm birth. And certainly the timing is also important, how preterm for previous pregnancy was, and also to whether it be spontaneous preterm birth or if it's induced. So for instance, those women who have had hypertensive disorders of pregnancy and they may have had an induction or a C-section early, they're certainly at risk of having it again in another pregnancy. So steps need to be taken in the next pregnancy to reduce that risk. Now, cervical surgery is another risk factor because that can weaken the cervix. Chronic medical disorders, as I mentioned before, multiple pregnancies certainly is a major risk factor. Those women that develop vaginal bleeding early in the pregnancy and even late in the pregnancy, that is also a risk factor. Additionally, if they have a short or dilated cervix, which we can detect on ultrasound and sometimes during the history, that can be detected. So the whole rationale for screening is to put in place interventions that can reduce the risk of preterm birth. Sometimes you cannot reduce the risk, or you can reduce the risk, but you can prolong the pregnancy. So instead of delivering a 30-weeker, you might be able to prolong that pregnancy to 34 weeks. So that is the purpose of screening and intervention. So unfortunately, these issues may arise in women who have no risk factors, which Dr. Young mentioned before. So we have to keep screening. So how do we screen in obstetrics? Screening, again, risk factors, and what is suggested by a lot of the professional authorities, such as FIGO, we recommend, and a lot of some physicians, and the practice will vary. What we recommend is cervical length measurement, and ideally by transvaginal ultrasound, meaning inserting an ultrasound probe in the vagina before 24 weeks pregnant, in order to identify that cervix is shortening or if it is dilating, right? So several studies have shown that this screening is very effective. So why do we do this? We're doing this in order to intervene. The interventions that can be done, what we use is a lot of progesterone. Progesterone is a hormone that is used to support the pregnancy. It has been found to be very effective in lengthening the gestational period in women found to have a short cervix that is less than 25 millimeters during the pregnancy, right? So a short cervix is found, especially in a woman who has no risk factors, is asymptomatic. Progesterone therapy has been shown to be effective. There's also the use of cerclage, that is what is called a stitch, to stitch up the cervix. And putting in a cerclage can be depending on the history of the woman. She may have had multiple losses, painless losses in the middle of the pregnancy. So a cerclage has been found to be effective. Sometimes a cerclage along with progesterone. And also too, when you're doing the screening, depending on how short the cervix is, a cerclage may be more beneficial than giving progesterone alone. So that is an assessment that needs to be done by the obstetrician looking after the woman. And well, there are other methods that have not as effective, like vaginal pessaries, not as effective. So what do you expect when you come in for, so let's say a woman presents with symptoms of preterm labor. What we do, assess the symptoms, the contractions, the cramping that she may have had if she's had some vaginal bleeding or passing water. We just assess what the symptoms are. Then an examination is done, usually by inserting a speculum, that is a metal instrument that is used to look inside the vagina, as you can determine how dilated the cervix is. And an infection screen can be done. We screen for infections such as group B strep. We may want to screen also for chlamydia, gonorrhea, any type of infection that may have precipitated this, so we can treat it early. Many times these women are given medications to try to prolong, slow down the labor. We use magnesium sulfate, as well as nifedipine and a myriad of other drugs that can be used, depending on what is available, and also taking into account the side effects. The magnesium sulfate we try to get on board because it reduces risk of cerebral palsy before 32 weeks gestation. So that is one of the things that we use as well. Also the urine cultures. There are investigations that can be done, fetal fibronectin, if it is available. Certainly we don't have that in our population, but where it is available, we can also use it to detect or determine the likelihood of the woman progressing into labor and delivery within a week. So again, ultrasound can be done, transvaginal ultrasound can be done to determine the length of the cervix, and also to the examination is done to determine how dilated the cervix is. So it gives us enough time to assess how the labor is progressing. Steroids is something that we use routinely in women at a certain gestational age that presenting preterm labor. We try to reduce the risk of the respiratory distress syndrome, intraventricular hemorrhage, and the necrotizing enterocolitis. We probably will hear more about those later in our talks, but as Dr. Young pointed out, these infants are at significant risk of morbidity. So whatever interventions that we can try to detect it earlier, it would be ideal if we could detect everybody who's at risk and reduce that risk of them delivering early. Even if we can't prevent them from delivering before 37 weeks, or try to reduce the risk of them delivering extreme prematurity. I would say that would be a good goal to achieve. So, because the more days and the weeks that we get, the better the outcome is for the infant. And I know the pediatricians are always grateful to us to, if we can prolong the pregnancy as much as possible, give steroids to reduce that risk, the risks of prematurity. So I would say from our obstetrician's point of view, screening is very important. Thank you. I think that is my 10 minutes.
All right, Dr. Tiffany Hunter-Greaves there. Thank you so very much for quite a comprehensive perspective there as we looked at the obstetric perspective just now. Let me restart my video. All right, so once again, thank you, Dr. Tiffany Hunter-Greaves. We're going to be moving smoothly into the next aspect of this evening's discussion, and it's coming from the perspective of the neonatologist, the local experience, looking at major complications. We'll be discussing why the work of NICU is so important, why a multidisciplinary team approach is important. And to take us through this section, we'll be having Dr. Roden, Dr. Sydney Roden, and also Professor Helen Trotman. Let me just quickly introduce both ladies for this evening. So Dr. Helen Trotman is, of course, a professor in the Department of Child and Adolescent Health at the University of the West Indies, Faculty of Medical Sciences at Mona. She's also a consultant neonatologist at the University Hospital of the West Indies. She does clinical research in the field of pediatrics and neonatology. She holds an MBBS degree, a diploma in child health, a Doctor of Medicine degree in pediatrics, and a Master of Public Health from the University of the West Indies. She also has a MS in bioethics from Clarkson University, and she pursued her fellowship in perinatal and neonatal medicine at the Oregon Health Sciences University in the USA. Dr. Sydney Roden successfully completed her DM pediatric program at the University Hospital of the West Indies in 2010. Pursuant to this, she acquired her fellowship in neonatal perinatal medicine at the Hospital for Sick Children in Toronto. She attained a wealth of knowledge, exposure, and experience in the intensive care management of critically ill preterm and term neonates, rotating through 3 major hospitals in Toronto, Canada. She's currently employed to the only pediatric subspecialty hospital in the Caribbean, the Bustamante Hospital for Children in Kingston, as a consultant neonatologist. She's a firm believer of God and stands on a strong foundation of faith. Outside of her daily routine at the hospital, Dr. Roden enjoys communing with others as an altruistic person, selflessly offers her time and services in rural communities in her country, of which she is very passionate. So the platform will now be taken by Dr. Sydney Roden and Professor Helen Trotman. And let me just get in a few questions. Dr. Roden, can you share with us the experience at the Bustamante dealing with the premature babies? How often do you see this? And what percentage of the babies that you care for are preterm? Additionally, what are some of the challenges that you face caring for them? And then we'll have Professor Trotman join us as well. So Dr. Roden, you can go first.
Cindy, you're muted.
Okay, I got it. Thanks, Trotty. All right. I was saying to Jeremy that I'm actually fascinated by his the spelling of his name, and I have now been given the opportunity to say that to him. So thank you for that introduction. A pleasant good evening to everybody who has tuned in tonight, who has taken the time out to tune in. And as you know, Trotty and I were discussing, and Trotty was saying, Cindy, I'm going to hand the baton over to you. And I said, I really don't want that baton, but I'm always up for a challenge, right? So we will go ahead. But before I even share my experience at the Bustamante Hospital, and I know Julie told me 5 minutes, I'm really trying to keep it for 5 minutes. I really have to send a really big shout out and thank you to Gillian and her support team, because I know no man is an island in terms of pioneering this inaugural event, right? Because we, and I know Trotty, you'll agree that we as a neonatologist, and if we expand the title, neonatal perinatal subspecialist, that in fact, we are the voices for the little ones, right? Nobody can hear them except through us. Right. So thank you, Julian, and thank you to the support team. As I said, Trotty, I really don't want to take on the baton, but I'm going to take on the baton because I feel the need, the ultimate need rather, to run the race accordingly. And I think a lot of us forget that the race, a lot of us believe that race starts at delivery, but it really doesn't. And Tiffany said it well, right? That it is a multidisciplinary approach, starting from the fetal stage, where that's the obstetric or obstetric counterpart, to the birth, to post-delivery, to post-discharge. And that is the race that we have to carry on for these little ones. Bustamante, and when Trotty talks, we will highlight the differences. But we at Buster, we are an outborn hospital, right? And by that, we accept transfers. We're the primary referral center or the hub in the island. So Princess Margaret wants to transfer a baby, we take that baby. Any other peripheral hospital, Mandeville's, St. Ansby, you name it, all of them island-wide. Bustamante is the place to go. So I think if I paint a picture on an open canvas, we have a bed capacity at a level, right? We have that bed capacity of 25. So if we were to accept all the premature babies, then you can imagine the status of our ward, where capacity is. It's really limited. Not to mention resource, which I can talk ad nauseam about. And this is a political forum, but I know that we we have issues in terms of resources. We have issues in terms of capacity. But being outborn and having to accept the transfers from the peripheral hospital, it really makes a very critical impact on our outcome. And I want us to have a paradigm shift, because when I talk about outcome, I don't talk about morbidity and mortality. I talk about survival rate. And that is what I want to be heard and had on our nursery. We don't have the opportunity of an intensive care unit as yet, right? I'll speak a little bit about the HDUs, which is via the PROMAC initiative, but we don't have that. We have to use our main ICU or pediatric ICU in a general buster, which only has 5 areas to ventilate a baby. So if we're taking in so many preterm babies, then you can imagine what we have to manage that space and what we have to deal with on our level 2 nursery, given the capacity and given the limitation in terms of resources. We've heard about the in terms of the number of preterm babies, and I'm not going to bore you or floor you with any more statistics at all, because I believe that behind every statistics there's a story, and I often like to share my stories on the nursery because that's what keeps me going, especially when I am faced with such challenges. So we have a parent blog where they will write. And I just wanted to share this particular very short story that a parent had written to us. And they said, we thank you, team at Bustamante. We held our baby. You gave us the opportunity to hold our baby in our arms. We shed our tears and we went home and told her little brother that we would not be coming home with a little sister. So those are the overwhelmingly sad stories that we're faced with, as well as we're faced with the positive stories where we receive photos of the newborn babies who are born prematurely at different stages in their lives. And we, try to engage and make it a family-oriented unit, right? And engage in the staff. And I have to thank hardworking staff, nursing staff, and the residents who toil daily and who are faced with challenges to try and improvise, right, with the limited resources that we have, as well as the limited capacity that we have. Now, just a little, overview in terms of when we don't have, we need respiratory support for the little babies. And I believe Dr. Young, Jennifer, went through the different categories of babies. So we speak of the microprem, which is less than 26 weeks. We don't have the resources to handle or to provide a positive outcome for a baby who is delivered less than 26 weeks, not to mention if that baby is about 500 grams or less. And that is unfortunate. And that's one of the challenges that we face. We're also faced with whether it's unethical or ethical, or I'm not being politically correct here. With that, we have to choose sometimes which baby goes on the ventilator, right? That's a sad state of affairs. But as I said, the team works together to try and make it happen and to try and move away from what is the mortality rate, what is the morbidity rate, to really, in fact, what is the survival rate. And just like how Trotty handed me the baton in terms of the development that I learned, right, from studying at the university, and she will get more into it, where there is a little intensive care unit, right? We don't have the opportunity at Bustamante, right? As I mentioned to you before, I will speak to the HDU, but they're now able to deal with 26-weekers, to deal with babies less than 1 kilogram. And that is the stage that we are at the Bustamante. So I also want to extend a thank you to the Ministry of Health under the PROMAC initiative, which is a program for reduction of maternal and child mortality, where you have the development of what is known as a high dependency unit, or what should be equivalent to that of a neonatal intensive care unit. What does that translate to? It translates to more admissions, right? It is a 10 bed space capacity. It translates to more babies being given the opportunity to have respiratory support, be non-invasive or invasive. So it's chartering a course, right? And I know that we are faced with challenges, but I know personally that without challenges, we can't grow. And that's what I advocate on the nursery despite our challenges. I now hand over to Trotty to share her experience at the university, and we can look at the contrast and we can look at the similarities, because at the end of the day, we will have a standard by which all babies, preterm babies, will be given that particular care that will be equal across the boards. And just like how she handed the baton over to me in 10 years' time, I'm hoping, God willing, right, that I'll be able to hand over to whomever, right? At that point, they'll be like, I can't believe you couldn't take care of a 24-weeker, 500 grams. Come on a 22-weeker on me. So that is the course that we're going to charter. And I love it. And that's why I have to revere Jilly and the support team for starting this, because this is not only national, it will go to regional and international status. So I thank you, and I thank you for allowing me to be a part of this symposium. So go ahead, Trotty, your turn.
All right, all right, let me just get in two quick questions that I hope Professor Trotman will cover in her presentation, and she tells us about the University Hospital of the West Indies, well, from that perspective, her experience there. Now, what are some of the challenges that you face? And in addition, why do you think that a multidisciplinary team approach is important? And let me also say thank you to Dr. Roden. My son, CJ, was at the Bustamante Hospital for Children only Sunday in the wee hours. So that's by mere coincidence. So I can attest to the importance of the Bustamante Hospital for Children. All right, Professor Trotman and Professor Trotman, nice to see you once again. And the floor is now yours.
Hey, Jeremy, I need to tease you too. Your team falling apart, man. Man, you.
No, you know.
Not Man U. Calm down. I know it's not Man U.
Okay. Okay. That's Simone's team. That's Simone's team. My team is Chelsea, but yes.
Okay, that's a little private joke between us. But anyway, good afternoon, everyone. I'd just like to thank the foundation for asking me to speak here tonight, because anyone who knows me knows that neonatology is my passion. So I just love to speak about it. And before I answer those questions, I just want to put why we do what we do. I'll give you two quick. I was walking in Sovereign, and just walking, and I heard somebody talk, and the person running. So I turned around and she said, "What's your name again, doctor?" And I said, "Trotman." She said, yes, you looked after my son. Let me get him. She brought this child. I looked up, this man towering above me. And she said, "You looked after him, and he's in sixth form in JC, and he needs it." And I said to myself, this time he's big, he's towering, and this was a little baby in the nursery. This is why we do what we do. And 2 years ago, I did the medical for one of our first, so a nursery was refurbished, and I will tell you a little about that, in 2001, when we got the NICU. And one of the first babies that we gave surfactant to, I did her medical for her to go to UTEC. This is why we do what we do. I don't know if Dr. Young would remember in 2001, that first baby, the unit wasn't open as yet, but we had a baby, a tiny prem, needed a ventilator, couldn't get into the main ICU. And Sister Davis is also here, was Dr. Young, Sister Davis and myself, and we put that baby on a vent prior to opening the new nursery. I hope Dr. Young remembers that. So Dr. Roden says, you know, she's taking the baton, and what I'm here to tell her is that growth occurs. Because if we look back just briefly at the university, we were right where she was at one point in time. And really and truly, our nursery had its sort of embryonic beginnings in 1961. And this just started in a small room on the maternity ward. And it was just providing basic care for neonates. In 1963, it moved to where the present location is. And at that time, there was what we call the 40 bassinet unit, and that's on the second floor of the ONG unit. And that's where we still are. And it has had refurbishments in 1982. And then the major one was in 2001. And in that time now, we got our neonatal intensive care unit. But just to let you know that I span the era. So I worked in that nursery as an intern and as a resident, where we were not able to ventilate babies. We used to take care of them with the bubble CPAP, and any baby who needed ventilation, we had to get them into the main ICU, Cindy, main ICU. And that was very difficult, because when you have a little 1,000-gram baby and you're trying to get that baby into the main ICU, and you have a 40-year-old man who had an accident, the 40-year-old man is going to win any day. And that was one of the reasons we said we needed to get our own neonatal intensive care unit. Prior to that, we were only able to ventilate like about 10 per thousand for every 1,000 babies who needed it. Since then, we have been able to ventilate 7 times that number of babies. So just to let you know that you will get there. Resources, always a problem, but we can still do a lot. And at the university, I will just use those small babies, those very preterm babies and extremely preterm babies, to just give you an idea that, so let us take those small babies. In the 70s, let us go even very extremely premature, less than 1,000 grams, right? You know, they had about a 92% mortality rate when we looked at the 70s at UWI, right? By the late 90s, we were down to about a 67% mortality rate. And that is where we really need at UWI. Now, I'm not saying every hospital is going to do this. Every hospital has to look at where they are in their journey and then forward plan, right? So at the university hospital, what has happened is that our babies between 1,000 and 1,500 grams, they have moved from about a 30% mortality in the 70s. And at our last perinatal, we had a 6% mortality. Babies between 1,000 and 1,500 grams, 6%. We still have a high mortality in 1,000 and below. But I would say, for us to move forward, as you say, resources. Resources is an important thing, because these tiny babies need things like nutrition, you know, that sort of thing, that we may not be, parental nutrition, we may not be readily able to provide at this point in time. But that's where we have to go. What you have to do is set targets, and you will get there, Dr. Roden. So that's why I'm handing the baton over to you. Now, the importance of a multidisciplinary team. I cannot even begin to tell you the importance, because a neonatologist cannot work by herself. Her nursing staff, I tell you, the nursing staff, they are my right hand, right? Nurse Nelson, my right hand. Nelson, no. Nelly, no. When I come in and I say, Nelly, take this baby, because they are my right hand without the nursing cares. And Sister Davis is in the audience. I want to say kudos to her. She taught me, as you know, to do things when I was a student, intern, resident, consultant. She's still teaching me. You can't do it without your nursing staff, right? They are there with the babies every minute. When a nurse says to you, I don't like how this baby looking, don't care how I examine that baby, and the baby don't look like anything wrong with them, I listen, because they look after those babies. So if they say that, so it is very important to have competent, capable nurses, and also nurses that care. And I must say that we are lucky at the University Hospital of West Indies. You know, our nurses care. I see it every day, right? So the importance of your nurses, the importance of like your dietitian. Now, we are not as fortunate to have dietitians who come on our rounds, but that's where we need to get to, as Dr. Young has shown you, right? You need that dietitian to be on your ward round, helping you, because we know that these tiny babies, initially they can't feed, you know, we have to be looking at their nutrition. Nutrition is such an important part of their survival that the dietitian does play a big role. Along with that, the pharmacists, because in a lot of places, the pharmacists are the ones who make up your total parental nutrition. That is for when the babies cannot feed, you're giving them the nutrients via a drip. So, you know, your dietitian, your pharmacist, our social workers, very important, right? Because as, and I'm sure the mother, Simone, who's gonna come, she will talk to you about the highs and lows, right? And a lot of times some of our mothers have other issues that will impact on their ability to deal with what is happening. So our social workers, our psychologists, we are fortunate to have Dr. Pottinger, who will be speaking to you, and Dr. Pottinger knows that anytime I'm on, she's going to get those referrals. She's going to get those referrals because our mothers, fathers, and sometimes we forget about it, family members, the little brother at home who's waiting for that sister to come home, who may not come home, right? So the psychologist is very important. We don't have them in Jamaica, but your respiratory therapists, you know, they are also very important. So really and truly, it is a team effort to really take care of these vulnerable. They are vulnerable. They depend on us for everything. They depend on us to pick up their cues. They can't open their mouth and say, you know, I can't breathe, or I feel in pain, or whatever. We have to pick up those cues. And it really depends, as I say, on that team effort. So we know we have challenges. Our challenges are resources. But guess what? We are resourceful people. We are resourceful people. Let me tell you something, the things we do, right? And the mortality rate, or as you would put it, Cindy, our survival rate, when people look at it, they say, but with what you have, that sort of survival rate. And I say, you know, we are resourceful. And there are tiny things that we can do. Yes, there are big things we need money for. We need money for that parental nutrition and so, but there are tiny things that we can do to help our parents, you know, get through this, to help our vulnerable population. So I would like to say that although the challenge really is to be able to deliver the kind of care we would like with the resources that we have available, but I think we are resourceful, right? And we can do. And as I said, over time, just like at the university, we were able to bring down our neonatal mortality rate. Cindy, you are going to be able to do that also. I was there when we couldn't ventilate babies in our nursery. We had to put them in the main ICU, right? Now we are at the point where we have outgrown our neonatal intensive care unit. So if there are any big donors out there who would like to expand our unit, we are welcoming you, because we have outgrown. Let me tell you, in no time, you know, you have 6 ventilators, you're going to outgrow that. We need more ventilators, right? Because the truth of the matter is, we are seeing more of these very low birth weight infants, and we are going to continue to see them, and to be able to manage them, we will need these things. But I am one that we say we can work with what we have and do the best we can with what we have. And the reason we do what we do is when that parent who you don't remember, you know, but they remember you, and they come up to you and they bring that child and they say, this was your doctor. You were tiny like this, and you're looking at this big strapping boy. I tell you, he was towering over me. And she said, you know, this, and that's why we do what we do. Yes, we will have sad moments, because the truth of the matter is we do not save all of them. But what I always say, if at the end of the day, because what I do at the end of the day, I look at what I have done. And if I can say I did all that I could have done, well, I can't do more than that. And so we must be aware that we are going to lose some. And so part of our management is how are we going to support these families who may have losses, right? And that's part of neonatology too. Sometimes, you know, we forget. And then the final thing I will say, because I know our 10 minutes up, is that we have to support our team, because a lot of times we do not realize, and sometimes people don't think, but every time we have a loss, you know, we take a hit. We have to go on, but we do take a hit. And sometimes if the baby has been there a long time, you know, it is very difficult. And so we must also take care of ourselves. But we do what we do because we do believe, and I believe it, that the greatest asset of any country is its people. And therefore, we have a mandate for all of these babies, for them to achieve their best potential that they can. So thank you.
Thank you, Professor Trotman. Indeed, that's why we do what we do.
We do.
And a resourceful people we are. And, you know, I must reiterate what you said. I mean, it takes cash to care. And therefore, every mickle makes a muckle. So for all those who can contribute to ensure that we can care for our miracles, I'm sure every contribution is welcomed. So once again, thanks to Professor Trotman, and of course before her, Dr. Roden, for their quite, once again, comprehensive coverage, looking at the perspective from speaking from the perspective of the neonatologist. All right, we're going to be moving along. I tell you what, our next presenter, I'm a big fan of, and I have been a big fan of her since November 1, 2019. I'll give you a quick story as I look to introduce her. Now, November 1, 2019, a miracle came into this world in the form of one CJ Brown. Now, when I got to the NICU, cleaning was about to be done, and they were just about to close off the unit for that particular time period. And one nurse, Claudiane Nelson Rodney, was there when I got there, and she was quite courteous enough to ensure that I was able to see young CJ before the cleaning lady got to her duties, and for that I am eternally grateful to her. So next up on the platform will be Nurse Claudiane Nelson Rodney, who says from a tender age she always knew she wanted to care for others when they were ill. Growing up in church, she says, I was part of a nursing home ministries, and that helped to cement my interest. Now, after completing studies at nursing school and being in the working world, she was exposed to neonatology, where she met her passion. She says, I've been working in the field for the past 4 years, loving, learning, mourning, and adapting. She further says, I hope to see the field grow to provide optimum care to all newborns. Adding that I am trying to do my part to assist in that growth. Ladies and gentlemen, I present to you Nurse Claudiane Nelson Rodney. Nurse Rodney.
Good night. I definitely remember that day as if it were yesterday, and I'm happy that this outcome was a happy one. Started shaky, as most preterm journeys do, and we have a happy ending here. Thank you for your introduction, and thank you to everyone that took the time out to join us today. I hope that whatever you learned here today, that you will go forth and share with everyone that you know. I'm a sucker for awareness overall. I think everyone should be in the know. And I think once you know what to do, then you'll do what you know to do. And that will help us to get to where we need to get, where optimum care is. Okay, so it all begins, nursing care of the preterm neonate all begins when the doctors say, obstetrics team, that's Dr. Greaves, would say, we have a preterm neonate and we need admission to the unit. This is where we start to work around like little elves to find a space. As we said, we are strapped for resources, but we try our best to make everything work out for these little ones. So we prepare the area, we get a warmer area to keep them warm as they come, and we prepare the support based on the need, based on what was spoken about earlier by Dr. Young. We have smaller babies and we have larger babies. So depending on the size and what the need is, then we would prepare that to ensure that the baby has the support that they need. We would prepare various levels of support so that if they don't require a high level of support, we'll also have what is required at the time, so we don't have to be scurrying around. Some of the supports that we prepare include the ventilator, as we know it, the breathing machine. Dr. Chapman mentioned earlier the CPAP, where that was the highest level at one point. It's really hard to believe. But as we live and learn, we realize that treatment group, there will be, once evidence-based practice is happening, then we'll have greater treatment coming in as we grow, and we're getting more techie in this world. So I'm sure that there will be other support that, well, we are not where we are supposed to be in terms of having the highest level of support, but I'm sure when it gets greater than the ventilator, I hope that I'll be there to see, especially for nursery receiving a high frequency ventilator. I hope that I'll be there to see the growth. We also have head boxes. That's for the bigger preterm babies. It's our little box that we put over the head with some oxygen or mixed gases to ensure that they get some extra oxygen to breathe. As doctors that presented previously stated, that it's a multidisciplinary team effort to take care of these babies. We are around these babies constantly, and as Dr. Chapman said, we are their advocates. We try to ensure that every change that is noted that seem to be bad or we're unsure about, that the doctor is informed so that we can both assess to know our plan of action to ensure that these preterm babies get the care that they need. They are our little warriors. They are very resilient, but they are also fragile. Something as simple as a tape on the skin can cause grave injury that we'll need plastic surgery team to help us to get under control. We need to involve the pediatric surgery team to ensure that we're getting this child the healing for a tape injury. So when I say they're fragile, they are very fragile. But when I say they are strong, you'll see them struggling to breathe, but they won't give up. You'll see them fighting with every fiber of their body to ensure that they stay a little longer, and they're doing everything to try to live a little longer. I want to have the strength of a premium one day. Okay. The premature babies have a lot of work to do. We have monitors that have various roles in the neonatal intensive care units that we would attach to our premature babies. These monitors range from pulse oximeters that will tell us the level of the baby's oxygen and the baby's heart rate. We have to learn the sounds of these machines to know what is happening with a baby. As was previously said, we're strapped for resources. So if we are nursing more than one of these preterm babies, we have to ensure that our ears are over to that one and our eyes are on this one. So we have to learn when the monitors beep high, that, okay, something is going on. When it's beeping low, we know, okay, something is going on as well, so that we can alert for help. Along with that, we have our warmers or resuscitators. We have to learn the different sounds for that as well. So if it's an issue with the temperature, we can address it. They are very small and tend to have temperature instabilities, and we'll have to do our job to ensure that we're keeping them at the desired temperature. Sometimes we have to ensure the use of cling wraps. A parent came and was surprised when they saw the cling wrap over their baby, and they're wondering why. And we had to explain to them the use of the cling wrap until we are in first world countries where we can have bear huggers and more functional warmers to help us to maintain the temperatures of these small ones. We also have our infusion pumps, where that also assists us to give IV fluids, intravenous fluids in the veins, and sometimes that is the only source of nutrition for our premature babies. As was previously said, that is why we need to have dietitians on our team, pharmacists, to help us with the mixing of our fluids for nutrition. So we have to also learn the different sounds of our infusion pumps. We have to know when the infusion is progressing. We have to know when, if something has happened that has caused the infusion to stop, if there's an air bubble, if there is occlusion in the line, something that is preventing the fluid from flowing. And we also have the ventilator that is also making noise. So everything in the unit, we have to learn the different sounds. So for some parents, those are trigger sounds. So as soon as we hear a sound that is not good, we have to ensure that we turn that off, because we don't want those parents to be frightened each time they hear it. And for some of the parents that visit, they tend to learn some of these sounds and know, well, they'll learn the bad sounds and they'll ask nurses, everything okay? And you'll have to assure them that that sound is not necessarily from your baby, or that's not the bad sound, that's the sound that we address before it gets to the bad sound. So that's just a few on the sounds of the NICU in the nursing area. Even though these babies are so small, they tend to take a lot of time, energy, and resources for us to care for them. And it will help us to, I'm sorry about that. We also focus on the support system that these babies have. And sometimes we end up being the only support system that these babies have. And we have to advocate for them. We have to sing for them. Sometimes we are non-blood aunts and uncles that has to be around the babies until the parents can come. Sometimes the parents are ill, unable to visit, especially the mothers for some of the preterm babies. I'm not sure if you heard previously where one of the causes of prematurity is preeclampsia, and sometimes mommies are in ICU or on bed rest, unable to visit, and we have to ensure that that baby has a soft touch, a soft voice, and to ensure that we have someone there to advocate for them. Sometimes when the resources are low, we have to make things from what we have. We have to connect things, tape it. Just yesterday, we had an admission and we had an issue with spacing, and we had to connect oxygen tubings. And I remember Nurse Sarika Williams saying, hello, get the blade and shave down that tubing so that we can connect it. And we had to get the blade, shave down the tubing, use it to connect, to stretch a line from where there was no oxygen to ensure that the baby that was coming could receive oxygen from another port that was in the ward. So we have to be engineers, technicians, aunts, and a lot of things going into this profession. As nurses, we know the parents need support. We have to be their support system, especially in COVID. I know it's hard. We used to have 24-hour visiting periods, and that has been cut down to only 1 hour. And the most times I hear the parents say, nurse, 1 hour with my baby, and they're ill babies. I can just imagine someone with a newborn wanting to see every milestone and being unable to. And we have to assure them each day they come, we have to tell them a story. Okay, so the baby's moving. Most of the time, these babies sleep for the 1 hour visiting time. So the parents don't get to see the true personality of the baby. So sometimes as they come, we have to teach them about it, teach them about the behavior of their babies to ensure that they have a feel of the baby that they'll possibly get to take home. I spoke to some of my colleagues prior to this meeting to get a feel of what they would like persons to know about nursing the preterm neonate. Nurse Alafia Gordon, who is one of my support nurses on the team, and she said that even though they are so tiny, they're hard work. And as nurses, we know that parents need support, and that's a part of our journey of nursing the preterm babies. And we try to ensure that they know that they are supported on their journey. I spoke to Nurse Chantal Morris, and she wanted everyone to know that the parents, to know that the little things or the positive small improvements that the little humans make daily is vital, and the parents can use that as encouragement, because anything can change. They are very unpredictable babies. Anything can change in the split of a second where you'll have to mourn. So for each good day, we always say, today's a good day. Let us smile and let us take it a step at a time. In the bad days, we'll rub the shoulders. We'll try to offer encouraging words. And I want us to also remember that once the baby is on the nursery, the whole family is on the nursery. And only the mother and the father is allowed to visit. And I know sometimes that's hard. So the support system needs to be there in the form of us nurses and the medical profession to ensure that these parents have a little support inside. And now in COVID times, it can only be one parent at a time that's allowed to visit these babies. So imagine if it's a rough day and the doctor is giving an update, you'll need to be there to support that mother to ensure that that mother is having a little help going along the way. Patience is key. The journey can be rough. Jermaine will tell us, Simone will tell us, but at the end of the day, when they survive, it's a party. Seeing them grow up, you're in awe of how such a little person could be such a big person now. I'm always amazed by their feet. I always look at their feet and I'm like, this little foot one day is going to take some brave steps. And I always wonder, what size foot will this foot turn out to be? And my colleagues always laugh at me because I'm always so fascinated with these small ones. But I want us to know that in the midst of life, there is death. And for me, that's the hardest part of nursing these preterm babies. And that is why we try to put everything into what we do for these babies. We know that there are possibilities and we know that there are promises. Some of the parents have been waiting a while for them. So we'll always do our best to ensure that these preterm babies or all newborns get the best care that we can give. And at the end of the day, if that's all that we can do, then we'll know that it was done and there's nothing more that we could have done. Thank you.
Right, so thank you, Nurse Nelson Rodney. I see a lot has happened since we last saw each other in 2020. Then you were Nurse Nelson. Now you're Nurse Nelson Rodney. Let me get that clear.
Yes,
Um,
sir.
Indeed, we thank you so very much for your dedicated service. You speak of the feet of those babies, but it's a major feat that the NICU is undertaking and continues to undertake and has been undertaking since 1963. I heard Professor Trotman say earlier. And when you said as well, Nurse Nelson Rodney, that you won't have the strength of a preemie one day. I felt that. And my reason for saying that, I remember one day I came to the NICU and I saw CJ and I saw the other preemies as well. And I was having a, not so much of a good day. And when I saw him fighting and saw the others, fighting, and I said to myself, well, if they're fighting, what am I as a big man complaining about, crying about? And I gained strength from that night in particular. So I have to make that testimonial. A rough journey it is, but certainly, as you would have said, as some of the other nurses would have said, as some of the other doctors, and as the old folks would say, sometimes these preemies, they go on to be so big in terms of their growth and what they're able to achieve in it. And speaking of testimonials, the next person on the platform, she will also be having, I'm sure, a heartfelt testimonial as well. She's very dear to me. Maybe the presentation I've been looking forward to seeing the most all night. I speak of none other than Miss Simone Forbes. She is a parent of a NICU graduate. She's a well-known sports personality who represented Jamaica in netball and 3 other sports. So she represented Jamaica in four sporting disciplines, including netball, former Sunshine Girls captain. And she's the current parent representative on the board of the Caring for Miracles Foundation. Ms. Forbes shares that she was moved to join the foundation because of the mission, because the mission reunited her resonated so deeply with her. She's the mother of a baby born too soon who has taught her so much about the strength of the human spirit and the resilience of these little miracles. So, and speaking of little miracles, you can hear that little miracle making a ruckus in the background. So Simone Forbes takes the platform now, and she'll be sharing with us her experience as well as some of the highlights, some of the lowlights, and some of the happy moments as well. And of course, what got her through these difficult times. Miss Simone Forbes, everyone.
Thanks, Jermaine. Good evening, everyone. I just want to apologize to have it on my mask. I really am sorry, but I have to have it on. You know how it is, it's COVID. And I have the sniffles, so I'm keeping it to myself. Thanks for having me. Good evening, everyone. You're gonna hear a young man in the background. That's our little miracle. That's the one. Thanks, Jermaine, and thanks to everyone I've been following. And I must tell you, the nurses, Nurse Nelson, the doctors, Professor Trotman, Dr. Louis, CJ is such a special child. He has so many doctors and so many nurses, and that's how I see it. He's one lucky child, blessed. But it's not about him right now, it's about me and my experience and how it is that I managed to cope throughout his journey that he's, of course, still on. I want to share just an experience I had, and I might be a little all over the place, but just stay with me for a second. It's one night I was in the nursery, and by the way, CJ was born. Let me give you a little background before I go into the meat of it. So CJ was born at 28 weeks. My water broke at 25 weeks, and I was hospitalized for 3 weeks at UA. And the last week of the 3, the Monday, I remember being scanned to check how much water is left. And I remember the doctor in the room. I'm laying on the bed, and he has the ultrasound thing on my stomach, and he's going and he's going and he's looking at the monitor and he's just checking. And I'm like, what is he looking for? And he's checking, and it was like over now half an hour, and he's still there looking. And I remember the other doctor coming in and saying to him, just report what you see. There is no water in there, just report it. You cannot make the water appear. There's no water in there with the baby. By this time, all the water, almost all of it. And he saw a little puddle and he's like, yes. And when he checked, it wasn't water. So CJ was inside with no water. And I remember the other doctor saying to him, it's okay, just report it and let's deal with it. By this time, he was only 27 weeks. And I remember them saying to me, okay, let's just see what will happen next. And I remember the doctor attending on the ward said to me, I'm going to check with the neonatologist. So to find out what we do now. This was the Monday. And they came back and said, well, the doctor said you're not in any pain. And so we're going to just keep examining you. We're going to keep monitoring you. And we just take it one day at a time. And I remember for me, that day in that room was the worst of the 3 weeks. Because at this point now, heart rate's been going great for the last 2 weeks. No, there's no water with the baby. No, I mean, I'm worried because I'm only 27 weeks and the baby wasn't 1 kg yet, which is where they wanted him to be, but he was 800. And I remember being in there and she's like, okay, let's just keep monitoring her. Let's just see what happens. And they're monitoring me every day. And I remember the Wednesday, I went for another scan. And when she measured me, I only heard her say, yes. And I'm like, what's going on? And she said, he's at 1 kg. And I felt like, oh my goodness, I could fly. I'm on the bed and she's saying, yes, he's 1. He's 1. And I'm like, he's 1? He's 1 kg. And so she's excited and I get excited and I'm like, yes, thank you, Jesus. Thank you, Jesus. I remember going back to my bed. And I agree with you, Renee, nurses and doctors are real superheroes. I remember going back to my bed and thinking, okay, baby, you can do this. We just need to get to 28 weeks, just 28 weeks. And I got to the hospital, 25 and 2. CJ was born 28 and 2. I needed to be in there for 3 weeks and he stayed for exactly 3 weeks. And he was born. And I remember being in the delivery room. And I'm talking, because I'm drugged up now, so I'm having a moment and I'm talking to the doctor next to me. And all I heard was just a little sound like a mice. That's if mice make sounds, I don't know. But I said, is that the baby? She said, yes. And I remember the doctor turned the baby to me, said, Mommy, this is the baby. Dr. Lynn, I think it was. And she just left. Now, for me, CJ being on the nursery was 78 days of, maybe the worst 78 days of my life. And not because the experience was bad, but because my baby was in the hospital. And I remember the first time I got to see him, it was a cesarean birth. And I was waiting on somebody to take me to the nursery and the wheelchair wouldn't come. And I was adamant that it's been 2 days and I need to see my baby. I don't know what is happening. I'm going to walk. And the doctors and the nurses are trying to stop me. And I'm saying, no, I've been waiting too long. I'm leaving. And at that moment, the wheelchair came and I remember going inside the room. I don't remember the nurse's name. I don't remember her name. But I remember looking at the baby and thinking, by the way, he was 1 kg and pure water. So by the time he lost the excess water, you can just imagine where he was. And I remember she looking by the way, he was in a room by himself. Because as I heard, he was born with blood infection urine infection. He was born with all of these things, low blood count, like so many things. And I remember thinking to myself, what did I do? This is all my fault. Why me? What's happening? This is not fair. I remember looking at him, and in that moment for me, and Daddy mentioned strength. For me, it was, but he's surviving. Like, he's going through all of this, and you could never tell that he's just going through this. So in my mind, I'm thinking I need to be on this journey with him. So this is your journey, Papa. I remember saying, this is your journey, and I'm on it with you. And the best, when I come into the nursery in the mornings, I'm looking to see if he's in his incubator. I think for me, every day, that's the worst part of going to the nursery. The unknown, not knowing. Yes, I didn't receive a phone call from the hospital, which is good. But you never know if I missed a call. So I don't know. So I'm going to the hospital or to the nursery, to his bed, thinking, oh God, please. And every time I'm going, I'm praying. Every time I'm walking to his incubator, I'm praying. And that was the 78 days for me. And Nurse Nelson mentioned having a parents, fathers and mothers visiting. There's a room there. And I thank the nursery every day for that moms were able to stay over. I don't know how I would manage if CJ was born now during COVID and not being able to see him. So I could sleep there, and I would, 78 days, I slept there 75 days. Just so that I could just jump up out of my bed at 2 o'clock in the morning and just run in the nursery and look on the baby. That for me was a big deal. And I think that is one of the things that helped me through dealing with my baby being in the nursery. That, along with the fact that I had the support of my family and I had friends. They don't pry, they don't push, but I knew that if my head hurt, I know I could call someone. If I needed dinner, I know I can call someone. If I need anything at all, there was someone there that I don't have to ask. I just need to say, or they would say, are you okay? Do you need anything? Because okay. They knew that's where I live. And so I had that support. And I don't think it would have been possible to deal with not having your baby with you for 78 days unless I had that support. So that for me was a big deal. So Daddy was the macho one, and he would come, and it appears as if it's not affecting him, but I know it was. But he would leave work 11, 12 o'clock at night, and he would come to see the baby. So I knew that was happening. Daddy would come, we'd sit with the baby, and every night I would sing him 2 songs before he goes to his bed. You are my sunshine, and this little light of mine. Because, I knew. By the way, I thought I couldn't have kids before I got pregnant with CJ. So for me, this was, yes, he was a miracle because he came early, but he was also my miracle. And my only child, the child that I didn't think I could have. So all of these emotions and everything was going through and happening, and I had to deal with that. Now, I'm someone who deals with emotion. So I don't bare my soul to people because I don't want them to feel bad, or I don't want them to have to experience what I'm experiencing. So in my mind, I'm saving them from going through it. So a lot of times things are happening with me, the baby, and I would be as calm as a cucumber. Nobody would know I'm going through it, but I'm dealing with it. And I remember one day, I'm about to talk about it and I feel like I'm about to tear up. I went into the nursery for my regular update, and Nurse Lynn said to me, by the way, the baby wasn't eating. So he was bringing up back everything, and nobody knows what was happening to him. And he started to swell, edema. That's what it's called, Nurse Nelson. So he was swelling up. So he looks like a regular sized baby. So I remember thinking that was the only, I don't know if it's good thing about the edema. He actually looked like a regular sized baby. And they're like, we don't know what is happening, Mommy, because he's not keeping down the food. By this time, he was having a few cc's of milk. So it's not like he was eating much. And he's not keeping it down. And so they don't know what to do because they're not sure what's happening. And I remember Dr. Lewis the night came to me and she sat down, and we know how Dr. Lewis speaks softly, and she's, you know, she's mommy, all right? And she's explaining to me what is happening with the baby and that they need to test my milk. And I'm saying, my milk? Yes, because we don't know what is happening with the baby. We don't know if it's the milk. The milk is something is wrong with your milk. Or she did say it like that, of course, that's just me. So they had to test my milk to eliminate that out of the equation as to what is happening with the baby. So it was a, we don't know, we have to try everything. And I remember the day it was pouring outside and I went to the window. I went to the window and I just bawled my eyes out. I mean, I think everything just came out. Everything I was holding in, everything I was saving everybody else from, just came out, and I cried, and I feel like crying now, and I cried and I cried, and I'm asking God, why is it that, why can't he get a break? Why can't the baby get a break? He's going through all of this, and every day it's something else. Like, it's enough already. And I remember I wasn't cursing God, but I'm like, give him a break. Come on. And I'm just crying. And I remember the security looking at me. And I really, at this point now, it didn't even matter to me what was happening around me. I just need God to give him a break. And I remember, and I finished crying and I wiped my face. I went to the bathroom and I washed my face. And I went back in the nursery and I held the baby and I just sang to him, because I remember one of the nurses saying to me, Mommy, your baby knows exactly how you're feeling and they can feed off that. And you have to, you know, you have to be positive around the baby. And when I left everything outside, I went inside. You'd never tell it's the same person who was outside bawling just now, because I'm now going back to rejoin him on his journey. And he's leading me, and I have to ensure that I'm providing every support that he needs. So if it means I have to be positive, then you best believe that's all. If that's all I can do, because I'm not the doctors and the nurses, then that's what I'm going to do. And I didn't have much experience with nurses and doctors prior to this. And somebody said something in the chat right now, and I just wanted to inject just a little thing in it. After that experience, and I've said it numerous occasions since, for me, anything nurses ask for, they should get. Like anything. And I'm having goosebumps saying that, because I remember CJ was ready to come home, and Professor Thames said, well, Mommy, anytime you're ready. And I said, anytime I'm ready. She said, yes, he's been ready from last week. But it was obvious you weren't ready for him. And do you know why? Because I knew that CJ had someone caring for him who, if anything happens, knows exactly what to do 24 hours of the day. And I didn't have to worry about if he's going to be cared for, if he's going to be fed, if that person has experience holding him. I didn't have to worry. So it's almost as if I made the NICU my home, and I intended to stay there until CJ was big enough to come home and I could manage, because I really wasn't ready. And so I had to bathe him, the whole, and I'm like, okay, get your mind around it, because clearly you're the reason why your son is still in the hospital. So I said, all right, you know what? Okay, I got this. Let's go. We got this. Now, we were ready to leave, and I'm saying, okay, if they're going to send him home, that means the baby is okay. And I think just that thought and just knowing that took a couple of years off of me. It means, because I know they're not going to send him home if he's not ready. So if they're sending him home, the only thing is that's in tiny. And I don't know how to manage that part of it. So, but you have to get with it, Simone. And I remember thinking, all right, let's go. We got this. Fix up room, get ready, because not even that was done, by the way. Nothing. Because I was living at the hospital, so that's our home. So I had to get ready for him. Now I remember, I'm going to wrap up, taking him home. I'll never forget that, January 17th, 2020. We took him home. I didn't sleep a wink the night, because now I had to watch to see if he was breathing. And I watched him, and if it looked like him not breathing, I touched to make sure that he's breathing. And he's breathing, okay, I'm comfortable now. And I remember looking at him on the bed and thinking, but how am I going to manage this with something? Sorry, he's so tiny. how do I cope with? And this is my first child, and he's a prem. He's barely 2 pounds. Okay, but the good thing is I had daddy, so daddy could hold him. If I can't manage, I'm afraid to break him. I'm changing him. The clothes don't fit him. The diapers don't fit him. Nothing fits him. Sometimes he doesn't want to eat, and I'm saying, okay, how am I gonna do this? But you know what happened? It dawned on me that, but hold on, this baby's been in the hospital for 78 days. He's just coming home. You haven't had him for how long? Enjoy it. Don't worry about it. It's almost, I had an epiphany. Don't worry, you'll be fine. You'll be fine. Just enjoy it. I remember thinking, this was a couple days after. All right, Simone, I mean, how bad could it be? Just make sure he's dry, make sure you play with the baby, but it's a learning experience, so enjoy it while you're learning. And of course, as soon as he goes, I want to call the doctor. If it looks like he's not eating the amount he's supposed to eat, I'm going to call the doctor. And how lucky this baby is. Dr. Lewis is his pediatrician, but then Professor Trumpman is also his doctor. Dr. Melbourne is also his doctor. So he's full of doctors. And I know there are persons, Nurse Nelson, who I can send a message to say, Nurse Nelson, something is not right. What do you think? And so it's the knowledge that, I have all these persons. Here we are with the support again, that I can say, okay, Dr. Lewis, I know it's late, but, I don't know what to do. He's having a cough. Dr. Trotman, okay, Karen, come and look at him. And she come on the outside in the parking lot to take a look at him and then go back to do her other patients. So for me, the number one thing I would say to parents, and there's something on here, what advice I'd give to parents who may be watching or going through this right now, to say it's going to be okay. It's hard, and it will be hard at first, and it's a learning experience, but understand that, trust and believe, you're not as strong as these kids. They are true fighters and they're survivors. And all you have to do is just to be on their journey. Just be on it with them. Be the support that they need. And ensure that you lean on your support. Because whether you're the type like me who don't, try not to burden everybody with it, you need the support too. So don't be afraid to reach out and lean on the people who you have in your corner. And make sure, because you're going to have to be strong for your baby. So make sure that you take care of yourself so that you're able to take care of him or her, and ensure that you have and use the support that you have. CJ is now 2. He turned 2 on that same November 1st, 2019 birth. He turned 2 2 weeks ago. And I said to somebody today, I don't know how they do it at the nursery, to have not NICU, but baby nurseries, to one teacher to 10 children. I can't manage CJ by myself. He is, and I'm not complaining one bit, he is 3 children in one energy. He just goes, and he never falls asleep until you put him to sleep. He won't fall asleep on his own because I don't know, I guess he's making up for those days in the nursery. But he is amazing. And when you talk about miracle, this little boy has dived through all his milestones. Some he's a little delayed, but that's okay. As again, it's his journey and he'll pick up, and I'm not worried because guess what? He's here for a reason. He has his own purpose. He has his journey, and I'm on it with him, and I wouldn't change anything. I really wouldn't, because I think his experience in the nursery has helped him, myself, daddy, all of us to deal with, and that's his journey. So why would I want to change anything on it? So for parents who might be watching, just it's gonna be okay. I'd really say that. It's going to be okay. Some days are gonna be harder than some, but it's life. Nothing in life is smooth sailing every day. And it's the same with the baby. You may have to go to children one night. You may have to sit up a couple of nights. but that's okay. Even regular term babies, you have to do that with. So it's nothing new or different. Just understand that these kids have their own journeys, and we just have to join the ride and be on the rails with them. But that's it for me. It's been a privilege for me to be on this foundation as a parent, sharing your experience. But I think this foundation has been doing and will do some amazing work with what we have planned. So Dr. Lewis, hats off to you and the other ladies for the work that you're doing, we're doing. And thanks to everyone tonight, of course, who joined in to be a part of this program. That's it for me.
All right. All right. Thanks, Simone, for that very heartfelt testimonial. You know, that testimony, Simone, should be in a book. You think? Her story is one of the most, I promise you, one of the most captivating you will come across. I mean, she said I was the macho one throughout the quote unquote ordeal with CJ, but you know, I saw her experience from up close, and one of the calmest and most collected person I've ever witnessed under extreme duress. I mean, she said it all, so I won't go back through it all, but certainly I am sure you would have been all ears as you listen to her this evening. Thanks once again, Simone. Right, so we're going to be moving along nicely. We have one last presentation to come. Last but not least, as they would say, who knows, saving the best for last. The next aspect of the discussion this evening will be looking at things from the perspective of the emotional toll. Pardon my papers here. The emotional toll on the family. And Mrs. Shireen Williams Hemmings will be taking us through this particular discussion. Let me quickly introduce Mrs. Hemmings for you. She's a medical social worker with a master's and a bachelor's degree, with master's and bachelor's degrees in social work from the University of the West Indies Mona campus with a clinical emphasis. She has over 13 years of experience working with vulnerable populations at the University Hospital of the West Indies and has served in her current capacity as head of the Department of Medical Social Work for almost 4 years. She's trained to facilitate interventions for most at-risk populations and provide motivational interviewing, a communication modality she incorporates when engaging her clients towards behavior change. Of course, Ms. Williams Hemmings has spent most of her career working with persons struggling to adapt effective coping mechanisms to deal with varying social issues. Her approach to social work is hinged on the premise that the whole is greater than the sum of its parts. Therefore, a holistic approach is incorporated to address clients' psychosocial needs through the assessment of the impact of their social environment. To unwind, refresh, and recharge, Ms. Williams Hemmings enjoys sightseeing, reading, and playing board games. So it's not all work. She does have some fun as well. So Ms. Shireen Hemmings will take the platform now, and just a few quick questions for her, as well as we have Professor Audrey Pottinger will also be joining us at this point in time as well, and I'll be bringing you up to speed with Professor Pottinger also. But before we do that, Mrs. Hemmings will take the platform now. And can you share with us your experience through the well, share your experience as it pertains the emotional toll that walking this path can have on families.
All right. Thank you very much, Jeremy. Thank you very much, Dr. Lewis, of the foundation for inviting me to be a part of this platform. I'm mindful of the time and I will try to be brief, but to give you insight. Simone and other presenters before hinted at the emotional toll of caring for babies born too soon. And I want us to first think about pregnancy on a whole, that journey filled with, for the most part, joy, anticipation for what is to come, and preparations for the newborn to join the family. And as Simone mentioned earlier, her baby being her only child, so she was quite excited about that. So I want to frame that picture for you, and to have situations whereby babies are born too soon and have to be admitted to the neonatal intensive care unit, that causes quite a bit of strain. It creates a change in what you were expecting, and have to refocus your lens and to adapt to a new norm, to adjust to the current situation. Or family, families are an agent of socialization, is an agent of support. And definitely in situations whereby there's a change, there's illness, we depend a lot on our family or our friends for support. And for parents or families with a neonate in the NICU, one of the things that they experience is a strain in the dynamics of the family. The stress of dealing with the situation, baby being in the NICU, not exactly sure of what is happening, the anxiety, constant state of panic. It's ironic, Simone mentioned, the fear or the anxiety in going to the hospital or getting a phone call, that those are some of the things that cause quite a bit of feeling of overwhelm, just unsurety on a whole for parents or extended family members, and of course, in situations whereby you have one parent navigating this new norm, you can just imagine how devastating this can be. Another issue that you may find too is the inability to bond with your child. You're expecting once you've delivered, you'll be taking your child home, you're able to, in the case of the mother, you're able to breastfeed and to just enjoy your child. And when you're faced with a situation whereby your child is in the NICU, you may not necessarily be privy to that sort of situation where you can hold the child, you can, just admire them and just allow them to hear your heartbeat, to recognize your heartbeat and just to know that they're safe and they're in a secure environment. Those are some of the things that affect the family significantly. Another thing is that the roles and responsibilities of family members may be altered, because now you have situations whereby extended relatives have to be providing additional support, especially if you have other children at home. So mom and dad may be focusing on the child that is admitted to the hospital. So they need support, they need assistance with getting children ready for school or just supervision in general. Simple things as doing laundry, buying food, preparing food. Those are some of the things that having extended support will make it a little bit easier, so that parents can focus on the child that is admitted to hospital without having to worry about home life and what exactly is happening. Self-blame is also something that affects not only the parents, mothers especially, but also the family on a whole. You know, you're wondering, what could I have done differently? Am I to be blamed for this? Does my partner blame me for what has happened? Those are some of the internal conversations that may be going through the mind of the mother. So that is something that we definitely have to be mindful about. We have to be mindful of how this new norm is not only impacting the parents, but the family on a whole. And that's why it's extremely important for us to incorporate a multidisciplinary approach. Well, in terms of my bio, I talk about a holistic approach. So I'm looking at all the parts. So I'm not just concerned about the baby that is admitted, but I'm also concerned about the parents. Do they have a good support system? In terms of financial support, is there anything that they need assistance with that will make this journey a little bit easier for them? Because having to worry about my child that is admitted to the NICU, who I'm unable to take home, maybe admitted for quite some time, but life still goes on, and having to deal with the regular stressors of daily life is something that makes this situation that much more difficult for parents. And I must say, especially when it's a single parent, because we have to be cognizant of the fact that such a situation, admission of our neonates to the NICU, can cause such a strain on the relationship of the parents that may result in them going their separate ways. And in cases like that, we definitely have to be looking, all right, is there anyone else in the person's environment that can provide additional support, who can do the little things that makes the parent who is going on that journey with their neonates a little bit easier. Also, prolonged admission may result in, extended relatives just, going their separate ways. They've been with you for a while, so they're unable to be there every day or to provide additional support. So they return to their own lives. And now you have the parents of the neonate basically on their own, having to trod this road by themselves. And it's really a difficult situation. We have to be mindful of how just a change in their environment can make it that much more difficult for them to cope and to just manage, because we are thinking of, or we're working, the medical team is working to get the babies well, but when the babies are discharged, they're going home to their parents. So we want well parents who are able to provide the support that they need, the support that the neonates need. And if they themselves are not well, then they cannot pour from an empty cup. So we are looking at the total picture. We're looking at the medical side. We're looking at the social environment and whether or not, a positive symbiotic relationship exists. And in cases where that doesn't exist, then it is our responsibility, meaning the social worker and the psychologist, to work with the parents, work with extended relatives to see how best we can help them to adapt effective coping mechanisms so that they are in a better frame of mind, in a better place to continue along that journey. And the last thing I want to say is that, we can't take it for granted that parents who have children in the NICU have strong support system. So we always have to be looking out, and of course, definitely getting all the relevant persons involved in the management and care of the neonates. And I will hand over to Professor Pottinger to continue with this discussion.
All right, Professor Pottinger, let me just quickly introduce you. It would be quite remiss of me not to do so, since I have done so for everyone else. You'll notice my background has changed a bit. I've had to change my device, so I'm sure you'll work with me. All right, so Dr. Audrey M. Pottinger, a licensed clinical psychologist, was trained in the US, the UK, and Jamaica. He's currently a professor of pediatric and reproductive psychology in the Department of Child and Adolescent Health at the University of the West Indies and a consultant at the University Hospital of the West Indies. And for the past 6 years, she has been providing specialty training for health and social welfare professionals through a one-year postgraduate diploma in loss, grief, and trauma, the management of trauma management out of the Faculty of Medical Sciences at the UWI. Professor Pottinger will now take the platform as we look to make up some time. Of course, Professor Pottinger, a question for you is, how does one support a family through their NICU journey? The floor is all yours.
Thank you, Jermaine. Dr. Lewis mentioned that I should bring up the rear, and then she sent me a message a while ago saying, the 5 minutes that I told you about, please cut it down because we're running over time. So I'm not even sure what I'm to say, but I think my job is easy because those who went ahead spoke about the support that the families need. Mommy Simone spoke about the informational support, the need for the parents to get information because that is support. Once they have information, they're empowered, they know what is going on in their child's life. Mrs. Hemming spoke about the practical support, and the other one, she also mentioned emotional support. There's already 3 main forms of support. I just want to say one quick thing because a lot has been said, and that is I really believe I support the multidisciplinary team approach, but I really believe that at the very beginning, when the patients are admitted to the NICU, it may be helpful to routinely inform of all the various supports, psychological, the social work, the chaplain, all of the support, rather than when a problem arises, then the parent is informed about the psychologist, because then they're saying, but I'm not mad. But if you see, if the psychologist is viewed as part of the team, when the child is admitted to NICU, then it may remove some of that stigma in seeking help. Because I heard Simone saying that she doesn't like to share, but she doesn't want to unburden. But that's fine to do with someone who is in the position as myself as a mental health practitioner. So I'm going to stop there, Jillian. I think I took up 2 minutes. Thank you.
All right, that was really quick, Professor Pottinger. Thank you so very much. I know your time was against you, but definitely we thank you for your presentation and for joining us this evening. Of course, we know that many of you have your questions, so we will be moving into that section now. So, and my team would have been browsing through the questions that you would have posted. So we will definitely be looking at those now and taking those those specific questions.
Jermaine, there actually have been proofs in the chat. There have actually been no questions. I think the presentations have all been so incredibly clear that nobody has really needed any clarification on anything, but there are no questions currently in the chat.
Okay, all right, thank you, Dr. Lewis. Well, we've come to the end of the inaugural staging of the Caring for Babies Born Too Soon Symposium. It was quite a comprehensive one, one that I'm sure everyone who would have joined this evening can relate to. I want to thank Dr. Jennifer Young. Also want to thank Dr. Tiffany Hunter-Greaves, along with Dr. Sydney Roden, Professor Trotman as well. Also joining us this evening was Nurse Nelson Rodney, Ms. Simone Forbes, of course, Mrs. Shireen Williams-Hemmings, who was with us just now, and Professor Pottinger. The full team was out this evening to present this inaugural symposium. And of course, definitely last but not least, Dr. Gillian Lewis, who would have made this possible and would have coordinated this symposium. And certainly, I don't know the date yet for the next one, but I'm sure I will be looking forward to it. So once again, thank you so very much for being here with us this evening. If any of my panelists have any questions for each other, you can be sure to go ahead and pose those questions. But if not, thank you once again, everyone, for joining this evening. And we certainly, well, I certainly look forward to joining in on the next symposium.